So welcome everyone, and thank you for being here with us tonight. As you can see, my name is Esther Helga Guðmundsdóttir. That's my Icelandic last name, and with a Master's of Science of Managing Health Services. I am a director of INFACT, the International School for Food Addiction Counseling and Treatment. And as of yesterday, executive director and vice chair of the Food Addiction Institute. And I am from Reykjavik, Iceland. We are here as all of us here are on the board of the Food Addiction Institute. All of us have been for multiple years working in the field of food addiction and some more in eating disorders. And so we have multiple years of experience and learning in dealing with those issues. And the good thing is that we seem to have solutions. And that's what we want to present here tonight. Phil Verdell is a founder of ACORN and the Food Addiction Institute. Phil is one of my teachers and supervisor in my work, and he is one of the directors of INFACT as well. Has been a teacher there from the beginning. He has written multiple books, and in my opinion, one of the people that has a deep understanding of what food addiction is and what recovery from it can be. So then we have Vera Tarman, an MD, author of the book Food Junkies, and the medical director of the Renaissance Treatment Center in Toronto, Canada. An addiction physician that has set up a treatment for food addicts up at the Renaissance up in Canada, which is an amazing achievement. Then we have Marty Lerner, PhD in psychology and an expert on food addiction and the CEO of Milestones in Recovery, an eating disorder treatment center in Cooper City, Florida, in the United States. All of these people, I think, are one of the experts in the field today. So it's an incredible honor for me to have all of you here to talk on the issue of the missing link.
This is going to be a presentation on what we call normal eater, emotional eater, food addict. And there's a chart which I'm going to talk from. I hope you can see it. It's small, but I'll be saying everything on it. So if you can't, well, oh, it just got bigger. So the reason we wanted to start here is that most people who have trouble with weight or overeating begin by thinking that it is entirely a problem of diet and exercise. Some people, after they've tried several diets, it's suggested often by their doctor that this may be a mental health problem and that they have an eating disorder. Binge eating, restricting, and purging of feelings are common with eating disorders. They're often related to unresolved trauma. And sometimes they have a weight problem, sometimes they don't. If people have a problem with their weight after they've had extensive therapy, they often recognize, well, maybe I actually have a food addiction or a substance use disorder or a compulsive eating. And the problem then is different. It's that you have physical craving, mental obsession, out of control will, and then often trauma and weight problems. one of the biggest problem, I just want to say that I personally have gone through that. I spent 10 years doing many different diets and gaining weight, dieting it off, and then gaining it all back. Then I spent 10 years doing several different types of therapy. And I learned a lot in the therapy, but my food problems weren't helped at all until I found out that I was a food addict. And I was actually found out I was a food addict when I was trying to stop eating one specific food, and I couldn't. And I mentioned it to men in my support group, and they said, "Oh, Phil, you eat like I used to drink." And it was at that moment, I was 46 years old, never heard the word food addiction, didn't know anything about 12-step programs, didn't know there was food addiction or substance use treatment for food. But I knew at that moment that my friend was a recovering alcoholic and that I was a food addict. The problem, since that I found out, is that many people have all three of these diseases. They are very distinct diseases, and each need to be treated differently. And in my case, all three had to be treated. How do you treat? What is the solution? Well, we know that the solution, if you're a normal eater with obesity, is that you need a medically approved diet, moderate exercise, and support for eating, exercising, and lifestyle change. We know that some people are effective in this. We know that almost every diet has people who have lost weight, but very few people who use any diet lose weight and maintain it. The research, the peer-reviewed research says that people lose weight and then they try to maintain it and they can't. They may go to the next diet and they have to start all over. So what could be going on? Well, some people have are working underneath their eating, life issues, difficult feelings. And basically what happens in emotional eating or an eating disorder is a person doesn't have the skills to be able to cope with very difficult feelings. And when they do, they often have difficult trauma, which they need help to deal with. So that's what the solution is. The solution is understand the difference between happy, angry, scared, and sad. Find out how to identify them when they come up. Be able to share them and then be able to work through them. And when difficult trauma or irrational thinking come, often work with a therapist or someone else to work through this. At that point, the person is like a normal eater, and they may still have weight problems and they have to do the same thing. But what if it doesn't work? That was my case. I was 80 pounds overweight, losing 25 or 50 pounds on a regular basis. And all of a sudden I had the realization I might be related to food the way alcoholics or drug addicts are related to their substance, that I had a substance abuse, in particular related to sugar and wheat. Well, the addiction model is that you first of all have to eliminate the foods that are causing the physical craving. Basically, what happens is that you ingest something or shoot it in your arm, that it's a drug. It goes into the bloodstream, it goes up around the frontal lobe of your brain, and biochemically changes the brain such that it becomes weaker, and because of that, needs more of what it usually takes. So if it was needing sugar, the sugar would make it weaker, and then it would need more sugar. That's called chemically dependent. And so when I thought I was hungry, that was really physical craving. I thought it was like I was starving, but I wasn't. I had plenty of food, but my brain kept saying falsely that I needed to have more. If you start dieting and kind of work against the craving, the disease is so strong that it starts affecting other parts of the brain. So the cognitive parts of the brain, the memory parts of the brain, and the executive parts of the brain are distorted also. And food addicts have thoughts that suggest and rationalize that they're eating, which aren't true. But even when they know that, they come up and still believe them. They also have things that are like blackouts. It's like they remember how good something tastes, but don't remember sufficiently what the negative consequences are afterwards. So these, which are called mental obsessions, are false thinking, and when they become elaborate, they start to create an addictive personality. And there becomes a need to actually regain the original healthy personality. This is often called by doing spiritual practice or a transformational therapy or the 12 steps. How much time do I have? 6 minutes. Thank you. So this is a progressive disease. It begins with mostly the craving. Then as it progresses, there begins to be addictive thinking. Eventually, there begins to be an addictive personality where you're in the disease or you're healthy. Now, it turns out that most doctors and most counselors and most general people know about normal eaters, but when they are still not having a function, they don't know they may have an eating disorder. And there are actually now tens of thousands of eating disorder counselors and several hundred treatment centers for just eating disorders. But it's different from those for food addiction, because with an eating disorder, the work is not to deal with the food at all, but to deal with the underlying issues. And the goal is to have you be able to regain your ability to eat normally in an intuitive way, so that you practice intuitive eating. It turns out if you're a food addict, your intuition has been distorted. You get cravings, you get false thinking. Sometimes you get actually a false self that you think you're doing all of this to yourself when it's really an addiction that's doing it to you. So that if a person who is food addicted is treated either with a diet or with talk therapy or any other type of just therapy, it's not going to work because the craving will take control. When I do work with Acorn and Shift and the Food Addiction Institute, I tend to refer people to food-related 12-step programs for long-term support. And so, because basically I needed that, I couldn't have afforded the amount of support I needed. I couldn't have paid for it. But in the 12-step programs, people help each other, giving to another food addict what they got free from other people. The work becomes that you actually have to not only be abstinent, but you have to remain abstinent. You not only have to challenge your negative, your irrational thinking, you have to be in a system where other people will help you challenge them when your head goes away. And you need some spiritual practice. The 12 steps are a particular spiritual practice which help people with addictions. As a spiritual practice, they aren't much different. It's just that they do go well with addictions. My hope is that soon we will start having, we're working now to get food addiction established as a disease. The American Psychiatric Association has said that many people who have eating disorders have a food addiction, and now it needs to be put in as a disease so that doctors and counselors can diagnose it and they can be paid for their work. There are, in fact, programs that are able to give treatment and point you to counselors.
Oops.
Phil, you're muted.
Oh. What did I say last?
Counselors. Go back about a paragraph.
What we need is counselors and treatment programs that deal in the addictive model. Yeah. And to do that, we need people trained to be professional food addiction counselors, like there are professional drug and alcohol counselors. INFACT, in my experience, is the best program for this. It's a joy to be teaching in that and to continue to work with folks. Thank you very much.
Hey, thank you.
Thank you, Phil. Okay, so before we come to Vera Tarman, I'm going to ask Dan, our moderator, to see if there are some questions for Phil before we continue.
Can't hear you, Dan.
You're
Oh, I'm muted. Okay. People are just saying hi. I'm from their whatever location they're from, and saying that they're really enjoying the information, that it's great information. So kudos to you guys on that.
Thank you.
Thank you, Dan. So no special question right now. So maybe later, coming up. Okay, so on to Vera Tarman, author of Food Junkies, medical director for the Renaissance Treatment Center in Toronto, Canada. Go ahead, Vera.
Okay, thank you very much, everybody. Hello, there's my better half, my Maddie dog. I would like to say first, before I start, that thank you so much, Phil. It's always really great to hear you speak. For those of you who don't know Phil, he is really, you know, we stand on the shoulders of giants, and Phil is a giant in the food addiction field. He's the one, he's like the father of all of us. And it's wonderful to follow you because, you know, I am following you. So thank you. And I also want to say a special thank you also, or hello to Marty, because he is, I mean, we're in a small pool of food addiction, but Marty straddles the larger world of food addiction and eating disorder. And that is a very, very difficult and hard to navigate world, because there's so much, I don't know if the word is hostility, but stuff that's happening. And he's one of our people.
Excuse me just for 1 second there, Vera. There is one question from somebody for Phil, I would imagine. Many argue that how can one be abstinent when food is a necessity?
Yeah, it's interesting. When we were lobbying the American Psychiatric Association, many of the psychiatrists said that. And the answer is really quite simple. If you think of alcoholism, people have to stop drinking. But what they have to stop drinking is alcohol. Mm-hmm. With food addiction, you have to stop eating the foods that are addictive. And the primary addictive food is sugar, and other foods like flour, which break down into sugar very fast, and then a few other small ones. So it turns out that when I became abstinent, I wrote down all my binge foods. There were 72. And but all of them had sugar, flour, caffeine in them. I then learned that there are 200 other foods, all the vegetables practically, all the fruits, and those I can eat.
Thank you, Phil. Thank you for that. So, Vera.
Okay. And I also wanted to say thank you to Esther, because Esther, I mean, you doing this whole seminar in the INFACT is like, it's amazing. I mean, you're a pioneer. I've said that many times, and I just wanted to say all of that stuff. And so now I'm going to say a little bit about me. I'm a physician working in this field of food addiction, and as Phil was kind of alluding to when mentioning about psychiatrists, there's not a great willingness to embrace the concept of food addiction. It still baffles me as to why. Maybe because we have eating disorder model that we kind of rely on, and who needs yet another thing to complicate the picture. So I'm going to let Marty talk about that. But I'm living in a world, a clinical world, where there's a fair amount of resistance to this idea, but there's growing science, and I want to just address a few pieces of that science. I will say, by the way, that there is some opening to this concept in the medical clinical world for the people. There's a sort of smaller group of, I'm going to say, younger doctors who are in what's called the low carb, high fat movement, and maybe the intermittent fasting movement, because they're discovering if we stop eating refined foods, lo and behold, metabolic syndrome or medical conditions related to obesity get better. And so there's a little opening there, and in a way they've stumbled upon our solution, and I see a bit of a divergence there, and so I'm actually more hopeful than I was. Of course, if Phil and his team can convince the DSM-5R or the DSM-6 to accept food addiction, we will be so much further ahead. Anyway, so medical world, can you go to the slides now? We don't need to look at that. Go ahead. So just as Phil said, this is the food we're talking about. We don't need to eat this. And from a medical point of view, can you go to the next slide, Esther? Next slide after that. What we're in the medical world, what we usually are confronted with are the consequences of that food that we just saw. And today, in 2020, medical clinicians are less likely to talk about why we got here to this state of obesity and the consequences of obesity. All of these are consequences. Most of them are now labeled under what we call metabolic syndrome, which includes diabetes, high blood pressure, and high cholesterol. But now we're starting to include other things like polycystic ovary, fatty liver disease, breast cancer, even Alzheimer's. Metabolic syndrome is just, it's a becoming a catch-all phrase to include all the things that are related to obesity. We could even say COVID consequences, because we're discovering that some of the people who go from just getting the mild benign COVID infection and actually get into the serious consequences of either death or other things tend to be people who have metabolic disease or are obese. Anyway, in 2020, we look at the consequences. We're less likely to look at the drivers of this, which are overeating of bad foods, the foods of that picture that I just showed you. We're more likely to treat these conditions, but we need to be talking about what got us there. It's a bit like, looking at the stream, and are we looking, I forget what that parable is, but the idea of we want to get the problem where it's starting, not the consequences. I think we all understand that. Okay, next slide, please, Esther. Forget that. This is actually about COVID, and I don't want to spend the time, but it's just to say that COVID should be included in this discussion too. Okay, go ahead. Next slide. Okay, let's just see. There's more to this. Yeah, let's just wait. Okay, so Phil has actually, go back. Phil has actually talked about this, which is great. And I want to say that we have 3 drivers of overeating that I want to talk about. And they are all in a part of the brain which we call the limbic system, but just to make it really simple, in the subconscious, out of like a part of the brain that is not control, it's not awareness, it's not consciousness. And our ability to know better and don't eat this because it's not good for me, using willpower, is in the frontal lobe, which is not this part of the brain that we're looking at here. These are Phil's very nice. He's done a really good job of categorizing basically disordered eating, and there's a biology behind all of them. Of course, we can have all of them, and they're all drivers to understand, and none of them are within our conscious control. We have the conscious control to choose our environment and the type of foods that we eat and the behaviors that we are subjected to, but to actually choose, it doesn't work. Even a normal eater will eat badly if they're eating our foods, our addictive foods, our industrialized foods. So we have 3 drives, and if you can go to the next slide. This is just a slide I like to show only how complicated the picture of appetite and satiety, or being full, is. It's very complicated. It's getting ever more complicated. And the blue lines, the blue side, is the stuff that most medical doctors, bariatric clinicians, endocrinologists, the people who are dealing with metabolic syndrome deal with. And the red slides are, the red and the orange are to do with the addiction piece, the piece that we're bringing to the picture. And they're all equally important. And, Esther's called this webinar the missing link. This is the missing link. We can talk as much as we like about food and how to, lose weight, but it's not working, and it's because there's a missing link, and the missing link is food addiction. And the clinicians like us who are, talking till we're red in the face to say, hey, don't miss this missing link. Okay, so the drives to overeat. Next slide, please. What Phil would call normal eaters, I'm going to call the hormonal or the endocrine model of eating. And it's not the neurochemical, that's the addiction piece. It's the hormonal piece. And I have probably another, 7 or 8 minutes. I can't obviously talk in great depth. But what I want to say is that the hormonal model, which is what the medical endocrinologists and basically doctors will accept, they'll say yes to this, is very true. It works. I'm not arguing this, but I'm saying that we need the other piece, the limbic pathway, the reward pathway, which is the second line underneath. This hormonal model looks at the hormones within us, and we have hunger hormones and we have satiety hormones. And if these are in disarray, which they will be in the food environment that we live in, so even a normal eater and an emotional eater can't be living happily in the food environment that we live in, the sugary foods that were onslaught. If we got rid of that, all of us, all 3 categories, would be eating better and be happier people. But in this environment, all of us are messed up. And how it can get messed up in the normal eater category or the endocrine model is that we can eat foods that will create hunger cues that are larger than our satiety cues. So our hunger cues are ghrelin. That's the hunger hormone that is released when my stomach is emptying, because it's been a few hours since I've eaten. And it's that kind of hunger that I'm just hungry, but I'm not starving. I'm just hungry, that sort of feeling. And then we have leptin, which is a satiety hormone, and it's like the brake on hunger. And it's that hormone that starts to kick in about 20 minutes after I've sat down to my meal, and I'm eating mindfully, I'm eating slowly, I'm eating socially. I'm not eating alone, gulping down something that will break down in 30 seconds. I'm not eating a meal that I'm done in 3 minutes. I'm eating a meal where it takes a half an hour to an hour to digest, so that I have that 20-minute break that can actually work and tell me I'm full. So ghrelin and leptin are hunger satiety hormones that constitute what we in the food addiction world call food sobriety, food serenity. And they are, I'm hungry and then I'm full and that's good. If we eat foods that are sugary or high processed refined carbs like flour, cakes, muffins, etc., we then also engage the hunger hormone insulin. And insulin is something that it's fuel. It provides. It takes sugar to the brain cells, and consequently, if I eat a lot of sugar, my pancreas will make a lot of insulin to deal with that sugar, and then we get a condition that can be called hyperinsulinemia, which means a lot of high insulin, far more than normal. And then we get into conditions that are that metabolic syndrome, that picture I showed you of all the things that can happen to the body. If we deal with those, which is what doctors do, there's a pretty good success rate. People who do the paleo diet or the keto diet often have stumbled on, they're using the insulin model, this hormone model, and find that lo and behold, they lose weight, they lose their craving for sugar, not because they saw sugar as a culprit or as an addiction, just because it was something that drove insulin, and so they had to stop it, and then sort of stumbled on the food addiction model. And I would be happy and content to just leave it there, but what happens is if you don't have this understanding, which I'm going to get to, I think I have, how much time do I have left? 5 minutes?
You like 8 minutes?
Okay, good. All right, good. If I don't acknowledge the addiction piece, then I'm going to start eating things that I think are low in sugar, but they're still very addictive. Because once you get into the reward pathway, you'll see that there's more than just sugar. That's the beginning of the story. Then there's flour, and then addiction is a chronic progressive condition, which can eventually just be food behaviors, which then end up being like binge, purging, restricting. Restricting, by the way, which in a food addiction model we call starving and restricting, but in this model, the endocrine model, we call it intermittent fasting. And a person who has a food addiction should not be intermittent fasting, because they're going to get caught and end up binge purging and doing that whole thing. I'm hoping and expecting that Marty will address this, because it's a big issue. Anyway, that's the drive of food. There's another drive that's the stress model. Dr. Lustig is the only one I've actually seen that's written about this, because he talks about the reward pathway and the stress pathway, and that's probably fits the emotional eating piece that Phil has nicely made as the second category, where I use food to quell my stress. And stress we can't underestimate that, because in the addiction model, we start from the reward pathway, which is what I'm going to talk about in a minute, but all addicts will eventually say they're not using their drug, whatever that drug is, whether it be heroin or cocaine or food, because they enjoy it. At a certain point in the game, late stages, Phil didn't talk about the late stages, that he's also really nicely drawn out the early, mid, and late stages of food addiction. But in the later stages, people are eating just to feel normal, because if they don't eat, they're going to feel awful. They're going to be, their cortisol level, their stress level will be so high that it's unbearable. It's unbearable. And we often say that addiction is, I can't eat because look what will happen to me, and I can't not eat because I can't deal with the withdrawal pathways, and that's got to do with the cortisol along with the limbic pathway. So cortisol is a very strong drive. So those are the two drives that, as I said earlier, a lot of the food plans out there address, and if you go to Weight Watchers or you do paleo or keto, they'll work. But we want to say there's another piece, and it is just as important, and in fact, maybe more important, especially in our food environment, where anybody, if you smoke enough cigarettes, you become a smoker. If you eat enough sugar, you're going to become a sugar addict, even if you're not predisposed. And of course, there is a predisposition. Sugar is a gateway, but cigarettes can be a gateway. Alcohol can be a gateway for sugar. It doesn't matter. One addiction is a gateway to another. And so the third piece is the limbic pathway, another drive for satiety. And this is the one where people will say with addiction, the stop switch is broken. I keep wanting, which is part of this pathway, and even though I want to stop, because the want is normal. We want to eat when we're hungry, and we like food when we're hungry, but it stops when we're full. Remember that ghrelin and leptin, the leptin will kick in. It will actually stop the reward pathway so that food is no longer rewarding and I don't eat it. But what happens here is that the stop switch is broken. And what is that switch? That switch is dopamine. Dopamine is the neurochemical that makes me want to eat the food and then stop. So when I'm hungry, ghrelin will kick in the dopamine, and so will insulin. And insulin is a more powerful appetite hormone than ghrelin. It will make me want to eat to the point where I want to push everybody away and let me have that food, or else I'll die, because you literally feel like you're going to die. That's all dopamine heightened. And even though the leptin is putting the brake on, even though my willpower is putting the brake on, the dopamine is larger because it's been hijacked and buffeted. It's like dopamine on steroids when it's food addiction, or when it's our food, the food environment that we eat, sugar and processed foods, make dopamine on steroids. And anything that normally would stop that can't stop that. That dynamic, when that becomes a chronic position, because I'm eating it all the time, and then I can't withdraw because of the stress pathways, then I'm stuck in a loop where I can't eat and I can't not eat. And it becomes from mild addiction to moderate and severe addiction. And that want can be so strong that I'm eating to the point of impairment, as Esther mentioned at the very beginning. I want to stop. I can't stop, even though if I continue, I'm going to become diabetic. I'm going to gain so much weight I can't go outside anymore. I can't walk anymore, et cetera, because that dopamine is just this big, huge want. We call it the hole in the donut, which, paradoxically or not paradoxically, it's very appropriate. So just understanding dopamine and the understanding of addiction, and we could call addiction, food addiction, an impaired dopamine response to food. Maybe if we did that, maybe that would appease the DSM-5R people. Serotonin and endorphin are the other two neurochemicals that are involved. There's also oxytocin, the love hormone, but you just need to understand dopamine, and then serotonin, which is I guess it's more of the calming feeling that you get after eating, like with dairy or with flour. Like some people say that they're savory rather than sweet. So that would be the savory people, and the sweet are the dopamine. Endorphin is that numbing feeling. Also, sugar will cue all of these. I can't go into the science about this, but Dr. Lustig and Nicola Vina talk quite a lot about the actual science of this, the receptors and how the food enhances these. But they basically put all of these on steroids so that the yes is bigger than the no. So that's a kind of an understanding of the biology. There's three drives that are in a subconscious part of our brain, which means that I'm not even aware that this is happening. But these foods that we eat, like sugar and flour, kick this in. And once it's been kicked in, unless you get off that wagon, it just becomes its own momentum, which is that chronic progressive piece. And it just gets worse and worse and worse. Like any addiction, it gets worse and worse and worse. And it's very easy to jump from this addiction to another and back and forth. Treatment for this, like I said, the paleo and keto may work for if you're in the first one or two categories, a normal eater gone awry, or an eating disorder person with eating disorder. But the only solution for food addiction or any addiction, if you want to get off the wagon of wants, this dopamine heightened response, this hypersensitivity to dopamine, that's what it is. It's a hypersensitivity. We have to stop. We have to cessate from the food that triggers this, that inflames this. Wait 2 or 3 weeks. We call that post-acute withdrawal. Other people will call that feeling deprived. Yes, it is, but the deprivation goes away. And then when this recalibrates and resettles, learn to live in a normal food environment, not the toxic one we live in, where these things will have a want switch and a stop switch that actually works. I think that's a summary of what I want to say.
Thank you. Thank you. Vera, you're just on time as well.
Good.
And so
there's a couple of questions that came in for Dr. Tarman.
Okay, you know,
it's right up here on the screen. Hopefully
I see that. So that's a very good question, and it's actually a really good question to lead into Marty's talk. But I will say that no, food addiction and behavioral addiction may initially not be the same. So if we're looking at, so I'm going to give my answer, but Marty may have another slant on it. But if we're looking from the context of what Phil was talking about, well, he actually didn't talk about it, but he has in other places, that mild to moderate severe food addiction, early days, probably it's just food addiction, but as the progression of the addiction continues, behaviors are included as well. Because if I don't eat, I restrict myself, I'm actually hungry, and hungry is will mean that my insulin, my ghrelin and insulin drives will be high, and my stress will be high, and eating is a way to quell those. So I can get caught up in the behaviors addictively. So I would say initially, no, food is one thing, but gradually over time, it's food and behaviors. And that's how I think eating disorder can be part of the larger continuum of food addiction. But I'm interested to see what Marty will say about that. If he does, I hope he does.
Thank you. Okay, so I'm going to get through a lot of things that we would have loved to hear more about. And some will that join the INFACT training for sure.
Yes.
Yeah.
Great.
Okay. So
do you want me to answer this, or do we want to move on to Marty? I'll leave it. You tell me.
So is there another question?
There is. There's one question here.
Okay. Let's take one more. Let's take one more question, Vera.
Okay.
While I'm getting Marty's.
Okay, so it says here, how are clinicians bridging the gap between prevention and evidence-based practice when it comes to food addiction? Can we encourage all specialists, especially those treating major chronic diseases, to prescribe, oh my God, food addiction counseling? Oh, I wish. I think that's our hope for all of us. We are, you know, the problem is until we actually get a designated addiction diagnosis, it's very hard to do proper research, because we can't, we need to have an entity that we're actually studying and that somebody's willing to pay us for. So the idea of evidence-based practice is, at this point, it's an N of 20 and N of 30. It's a small sample size, because it's people like me working in the field, and we just simply can't afford the large numbers. So I think that question is really a wish list. We would like to be able to get evidence-based research. We've got some people who are already doing that more and more. Like, we're sort of at the cutting edge of moving from studying about rats, which is what Nicola Vina has done, and now she's actually starting to include clinical people, like actual people, and studying. And we're at that stage now of bridging and moving into that, but we're not at the stage where we can say this is you know, fully evidence-based, not yet. It's clinical based, and well, that's basically what it is. We have a lot of clinical experience.
Okay, thank you, Vera. Okay, so let's go on. I'm sure there are more beautiful questions, and we may want to address some of them at a later date if we have time a little later on.
Yeah.
But I do want to get Marty Lerner on.
Yeah.
And thank you, Vera, for giving the word basically to Marty Lerner. And I already introduced you, Marty. Are you ready to go?
I am. Oh, what an easy task, tying all this together in 15 minutes.
Right.
Oh my God. Anyway, kudos to Vera and to Phil, and of course to Esther. So at the risk of sounding like Food Addiction Institute heretic, let me go through a different
steps.
Huh? Anyway, if you at the risk of sounding like Food Addiction Institute heretic, like burned at the stake. Anyway, let's go on to the next slide, please. Okay. Can you all hear me okay?
Yes.
Okay. So to me, this is one of the more important things I have to say. And basically, I'm just going to read it. You know, very often disordered eating or eating disorders are approached as a psychological problem involving poor impulse control or self-control and emotional eating. And some of you, both of you kind of alluded to that before. I would say, with the exception of only a few treatment centers, everybody is looking at quote unquote bulimia, anorexia, bulimorexia, binge eating disorder as psychological or emotional eating. And from where I sit, and I'll explain this a little bit more in detail, not recognizing or acknowledging and treating, more importantly, the biological drivers of food cravings and overeating very often leads to a poor outcome in treatment. And I'll even make the case that that's also true for restricting types of eating disorders. So from where I sit, treatment of an eating disorder, and I'll say AKA most forms or flavors of food addiction, really demand attention to three pieces that make up the perfect storm. The first is the nature of the substance. So in this case, we're talking sugar, flour, or high glycemic foods, or a rose by any other name is still a rose, usually very highly processed foods that are high, what we'll call high glycemic. So it's the properties of the foods consumed, but it's also the nature of the person, or as Vera was alluding to, the psychological or behavioral components or habits of the person. And last but not least, the biology of the individual. I would add to that is the environment or the culture. And that'll become a little bit more clear on the next slide. The next slide. So this is, ASAM is the American Society of Addiction Medicine, and they're kind of a group of, a lot of them are recovering physicians, psychologists, professionals, and I think this is a brilliant statement. Addiction is a treatable, chronic medical disease involving complex interactions among brain circuits, as Vera was alluding to, genetics, the environment or the setting, and an individual's life experiences, your learning history. People with an addiction use substances or engage in behaviors. By the way, the American Psychiatric Association added compulsive or a process addiction, compulsive gambling, which isn't a substance per se use disorder, but still an addiction. Engage in behaviors that become compulsive and often continue despite harmful consequences. Quick footnote, the American Psychiatric Association and the American Association of Addictive Medicine, Society of Addictive Medicine, does not think of food or compulsive overeating as they included compulsive gambling, but not compulsive eating, binge eating, food addiction, or anything like that. But if the shoe fits, I would slip it on. Prevention efforts and treatment approaches for addiction are generally as successful as those for other chronic diseases. That's the good news. So to recap, nature of the person, nature of the substance, and nature of the environment. Next slide. So as was asked of Phil and whatnot, I always get asked, as I'm sure Phil and Vera do, and Esther does, how can food be addicting? Well, to me, it's a lot of semantics. But what I explain to people, because they'll say to me, well, you know, drugs, alcohol, even compulsive gambling, they're both substances and actions or behaviors that aren't necessary for life. So, you know, that makes them different than food. And my point is, well, food may be necessary for life, but so is water and air. But I haven't found anybody that's opened a treatment center for compulsive water or air consumption. So go figure. Drug addiction, as Phil alluded to, not all drugs are addictive. Food addiction, not all foods are addictive. So I think some of this issue is more semantics than anything else. You can go to the next slide. And that's a picture of us. And the next slide.
Looks like we lost streaming somehow. Help, Esther. Looks like we lost Esther.
Oh, you lost Esther.
Something happened with her internet connection, I guess.
Well, while that's going on, all I'm going to tell you is that the next slide was just a list of 7 criteria from the American Psychiatric Association of what addiction is. So they have these checklists, and they'll say tolerance, which we all know is more of the same behavior or more of the same substance to get the same effect. Not a lot of rocket science. Withdrawal symptoms, we alluded to that. I think Vera made a very cogent statement. I have 3 chapters personally and professionally that I've observed with people. The first chapter, whatever the substance of the behavior is, it works great. You start drinking, you're, Fred Astaire or John Travolta, depending on how old you are. Second stage, you're not quite as illustrious as them. And in the third stage, people are calling 911 because they think you're having a convulsion. Basically, end stage of any addiction is where you're doing it not to feel high or not to feel better per se, but to avoid what it feels like to not be doing it, aka withdrawal. That is certainly true with food addiction and most forms of eating disorders. Doing more for longer periods than intended. Unsuccessful effort to cut back. How do you spell diet or intermittent fasting or whatever? Which is part of the topic of all of this. Giving up occupational, social, or recreational activities, aka isolating. Most people with addiction, by the time they are looking for help or need to look for help, are probably doing their behaviors with their substances or behaviors in isolation. Not a lot of people with addiction are very active. Welcome back, Esther.
Thank you. Can you hear me now?
I can hear you. How about a slide?
Okay, I'm going to get us a slide. Just
Do I get 5 bonus moments?
Okay.
So going through this checklist, here's what I think while Esther's doing that. We're on the substance use disorder slide with all the different criteria for addiction. But here's the rub. I look at this, and this group of psychiatrists that got this together did 2 things. One, I think, is a positive. They used to say a different category for cocaine addiction, a different category, keep going, a different category for alcohol, a different category for opiates, that's it. A different category for compulsive gambling and whatever. Back one, Esther. Back one, Esther.
Okay.
Thank you. And they never consolidated this. So the good news is they finally got it together, and they said substance use disorders and grouped them all together because they all have these common traits. It really doesn't matter when you look at this whether your flavor of addiction is a substance like alcohol, methamphetamine, or an opiate. And for that matter, they've added compulsive or process addiction, gambling, to the mix. But I'm going to argue, and this is why I think sometimes it's a little confusing to people. I would say that all the different flavors of eating disorders meet these criteria. I would even argue that both restricting and binging and purging forms of anorexia meet these criteria. And also, if you went a little bit more in depth with what Vera was explaining, I can make the case for the neurochemical dopamine and serotonin and cortisol tie-in with all of that. So bottom line, that this is the official definition of a checklist for what constitutes, in my language, an addiction, in their language, a substance use disorder. And then they went and said, well, if it's mild, it's only 2 out of the 3. If it's moderate, it's 4 out of 5. And you get a perfect score if you're 6 or plus. So for those of you wanting extra credit, you can fill all of those criteria. Next slide. How are we doing on time?
We need to give you a little extra. So I would say like maybe 8 minutes now.
Okay. Bonus minutes. I love it. Okay. this is just to give you an appreciation from where I sit. And I have a little bit of a research background. So my background was really doing surgery on rodents. And then I got into humans, but I didn't cut them. I just studied them. Unfortunately, most of the rodents that I did some surgery on didn't quite make it. Anyway, if you look at this list, it just gives you an appreciation of how many variables or factors influence the regulation of appetite and or pathological eating. Genetics, I'm just going to give you a quick example of that. Vera was talking about, I said ghrelin, but ghrelin and leptin, insulin and cortisol. Genetically, for instance, there's a small contingent of people that are born with a problem with their leptin, and then people who acquire something called leptin resistance, like insulin resistance. So if ghrelin is the accelerator and leptin is the brakes, by the way, you produce more leptin the more adipose or fat tissue that you have. Guess what? If you're suffering from the symptom of obesity or are genetically predisposed towards obesity, what'll end up happening is, despite having more leptin than the average bear out there, you've developed leptin resistance. So the quantity of leptin is not a driver of satiation, just like ghrelin may not be the total driver of appetite. Reward circuits was talked about. Dopamine is the golden child of addiction. Dopamine is what you get a little spritz or surge of that makes you feel good. It's a dramatic surge when you do a very processed drug like crack cocaine. And it also is a surge that you would get if you're addicted to sugar. And by the way, if you're anorectic, even restricting type, you may have developed or acquired a dopamine surge from restricting, and you may get the opposite effect when you eat, feeling depressed. Role of serotonin, same kind of an issue. I won't go through all of that. Another one that I think is important is classical conditioning or associative learning. So one of the things that Nicole Avino had been studying, she's calling it hedonic eating, but basically it's not a new concept. If I took you into a movie theater and you were watching, remember movies before COVID? If you were watching a movie, usually before the movies I go to, you see a Reese's peanut butter cup marking across the screen playing trumpet and, bonbons and all this candy and Coke and all of this stuff. If you're a food addict or have some forms of eating disorders, what will actually happen is the actual site, the external stimuli, will create a physiological reaction. How about dumping insulin and lowering blood sugar? People with eating disorders and food addiction will have a pronounced sensitivity to external cues. So when you see external cues or salient food cues like smell, taste, sight of food, talking about food, they'll trump, excuse that pun, internal cues, even the ghrelin, grumbling your stomach. Even if you've eaten 2 hours before, external cues will override the physical satiation. Hormonal was talked about, ghrelin, leptin, insulin. I would add cortisol to there. By the way, cortisol can do two things. In my experience, I grew up with a mother who was a normal eater, and she would say, I'm too upset to eat. And I would say, I'm too upset not to eat. So go figure. I think that has to do with learning history or classical conditioning. That focuses in on emotional eating. Trauma. I wish I had more time to talk about it, but part of the brain, I'll show you a slide of it if we have time, called the amygdala, kind of remembers emotional events as opposed to the prefrontal cortex that's more the impulse control moderator. I call it the prefrontal cortex the Mr. Spock part, logical, and the amygdala is the reptilian brain. It only knows how to avoid pain or to go towards reward. And emotional eaters are hardwired in that amygdala area to distort, as was said, euphoric recall about how sedating or good the food is and blocking out the consequences. As a matter of fact, the amygdala plays a starring role in all addictions. Processed foods, junk food, environment setting. The more processed the substance, the more addictive. Cocoa leaves in India and the Amazon. You chew cocoa leaves, you're not necessarily going to get addicted, but it helps with attitude and to get you up the mountain. Process it into cocaine, you'll get a little bit high. Process it into rock cocaine, you'll definitely get addicted. Start smoking it and we'll see you in rehab. Well, we can thank the Japanese in 1972. They processed chemicals to give us high fructose corn syrup. That's about as high processed a artificial sugar as you can get, and it is very addictive. So if you take sugar cane, you process that, the more you process a substance, the more addictive it is. Opiates become more addictive when they are processed to heroin, and need I tell you about fentanyl. Plasticity and cross addiction, all I'll say to you about that is I refer to that as switching deck chairs in the Titanic. In my world, I see a lot of people with bulimia that want to trade in the bulimia for becoming better at restricting. I see food addicts that want to intermittent fast or take an anorectic stance, and they become anorectic without being underweight. So what ends up happening with a lot of eating disorders or food addiction is you just switch chairs on the Titanic thinking that you're not going to drown. That goes to switching of eating disorders, stress and cortisol, we talked about, and trauma, which is a learned response in that amygdala. And food addiction and or drug addiction and or any addiction becomes a maladaptive coping mechanism to all of that. So that in 25 words or less just gives you a clue of how complicated and one size doesn't fit all when you look at this. Next slide.
And we need to have a kind of a bottom line pretty soon.
Pretty soon. Okay. Skip to the next one.
Okay.
So from where I sit, when you look at patterns of use or forms, I look at eating disorders as primarily addictive in nature, but having emotional or psychological components, behavioral components, biological components, etc. So when I look at compulsive overeating, whether it's grazing, binge eating disorder, binge eating with compensatory behaviors, bulimia, bulimorexia, the rest of it, whether you call it an eating disorder or food addiction, for me, they're interspersible kinds of terms. Next slide, and we're almost done. So, tenants of recovery need to identify and abstain from the addictive food. We knew that. You need to address the mood or psychological issues. Quick sidebar, in my level of care, which is residential and partial hospital, most of the people I see have co-occurring mood disorders that predate their eating disorder, usually depression or an anxiety disorder. We also need to address the physical component, the symptom of obesity, diabetes, cardiovascular disease, etc., and eliminate isolation, participation with community-based support groups, and cultivating a functional spiritual relationship with an entity other than self. One more slide. So my acronym is SMURF. That's the formula, the solution. Spirituality or support, meditation, or if you wish, mindfulness, exercise, rest, and food plan. Those are the essential elements that we utilize, bottom line, to sustain recovery. One more slide. That's where you can get a copy of the book or more information. And one last slide, which is our commercial.
Okay.
Coming attractions. So if you sign up, you'll find the future workshops are going to focus, at least on my end, on updated evidence of the phenomenon of craving and the role of external events. In other words, beyond the biology and the food. Hedonic eating, what it is and what food addicts, do they do it? Once an addict, always an addict, question mark. Can you ever eat sugar again? Where does the addicted brain hide? Internal cues, intuitive eating, and the myth of dieting solutions, and treating food addiction and eating disorders. Those are the things that I understand the Institute in part will cover. So I thank you for paying attention, and I enjoy doing this.
So we're about to end this incredible session here, and I must say, I get to listen to those folks quite often, and I am always just so at awe and amazed with the knowledge and wisdom and experience that comes out of the mouths of these people. And his Dr. Robert Lustig, Nicola Vera, have gracefully are teaching and lecturing at the INFACT school. We have Teresa Wright, who is a dietitian as well, with 40 years experience in working with food addiction. We have Peyton Jonsson, our sweetest sugar, who has developed a sugar diagnostic tool. The newest addition is Dr. Gautam Tavarut, who is a doctor in addiction counseling and treatment. And he's starting to work with us in the fall as well. And it is, as I said before, the first school that has gotten to be evaluated and certified for the teachings for certifying food addiction counselors or professionals. So in order for change to happen, we need to be willing to change our methods. And we are slowly but surely adding on to the knowledge that professionals already have, so that we can become a better for our clients. And they need it because they're dying by the hundreds and thousands of this disease, and they don't even know that they have it. So any last words from Vera, Phil, Marty, or Dan?
I would like to say something, if I can,
Yes.
about the program, the INFACT program, that there are, as I think Phil alluded, or maybe it was Marty, that there's a lot of counselors out there, there's a lot of programs out there, but I'm not aware of one that is pure food addiction, where we diagnose the problem and we treat it from a food addiction point of view. I think it's unique, and this is a great program because we got it, as well as we have the science, as we're up to date with the science as far as it is. So I think it's the best program, and that's why I put so much time here. That's it for me.
Thank you, Vera. And Phil, you wanted to say something.
Well, this thought kept coming up during the thing. So this is my learning. We think in the United States that about 2/3 of the people are overweight and about 1/3 of the people are obese. And David Kessler, who was the head of the Food and Drug Administration, has estimated now that 50% of the obese are food addicted. So that means there's about 70 million people who are food addicted. And those who are in the more progressed state, the thought I kept having is, what if you were trying to lose weight and most of the foods that you were eating had something like heroin in them or cocaine? Well, it turns out it does. Most of the things have, most of the foods, about 30% of the 80% of processed foods have sugar in them. And if you're doing sugar and trying to lose weight, you're eating something that makes you want to eat more. And I think that's one of the major reasons why we aren't able to deal with obesity. That's all.
Thank you, Phil. Any last words from you, Marty?
No, I always think, gee, I might have to do this tonight, and then once I'm here, I don't want to stop.
Right.
Yes.
I think that there's a level of energy that's the aggregate of all the people that are here, and that when we get together, it's almost like we can't wait to hear each other, but also it's very validating because a lot of us work solo. You know, it's not like that we all work together. And yeah, we have people that are on the same page as us, that at least where I work, I have 18 people on staff. But I don't have this. And when we get together, whether it's in Massachusetts or it's here online or at some conference or somewhere, it's both rejuvenating and validating. And it, for me personally, it's like going to a meeting. You know, it's something that I need to sustain myself professionally.
Thank you, Marty. We'll keep doing that.
Yeah.